Dr. Jayanthi, may I request you to please very briefly cover what Vinay has sent you in about, say, 10 minutes.
Can you ask the host to allow me to share the slides? I'll finish up in 10 minutes.
Yes. Himanshi, please allow Dr. Jayanthi again to be the co-host. And then, Deepak, you can make some concluding remarks and then close. So I will take leave, please.
Thank you.
Thank you. Thank you so much.
Thank you, sir. And I'll just cover this topic, which was not covered in the initial phase. And I think this is an important topic because the entire management of ulcerative colitis is ultimately dependent on the assessment of the extent and severity of the disease. This talk was to be delivered by Dr. Vinay. He's busy with the surgical procedure, and hence I'm presenting on his behalf on his slides. So the points for discussion will be just again a brief introduction. There will be a lot of overlap with already most of the things that have been covered. The clinical scoring system stresses the disease extent and severity, the laboratory tests, and the endoscopic evaluation. So this we have already covered. Just to recapitulate the fact that ulcerative colitis is a disease which is starts from the rectum, restricted to the mucosa and submucosa, and it's a lifelong disorder. So it is typically characterized by relapses and remissions, and the hallmark is classical blood diarrhea with rectal urgency and tenesmus, and extraintestinal manifestations occurs in about 20% of patients. So the key diagnostic features of ulcerative colitis we've been discussing throughout this evening. They are the clinical features. Classical is the bleeding per rectum. The endoscopic features, which I'll be mentioning and discussing about that. The laboratory investigations, where CRP may have a role along with fecal calprotectin, and classical histological findings of goblet cell depletion, ulceration, cryptitis, and cryptapsis with crypt distortion, branching, and atrophy. Why do we need to define the severity index? It is important because this serves as a guide to select the case for appropriate treatment, whether it is surgical or medical. I think that's very important, and hence we need to know the extent and severity of the disease. It also helps to prognosticate the patient's condition. So let us go through some of the clinical scoring systems. All of them are actually done on the calculator. So we have the Mayo score. We have the score ranges from 0 to 12, the highest score that indicates a more severe disease, scores that are compared with previous scores for response to treatment. And then we have the Mayo Index, where we have the physician's global assessment and other criteria that includes the patient's daily abdominal discomfort, general sense of well-being, performance status, and physical findings. The second classification is the Montreal classification, which has a severity index of 0, S1, S2, S3, and S4. Basically, it contributes to the number of stools per day. So that assesses the severity of the disease. True love and which criteria was also discussed by Dr. Sujoy. And this is, I think, a simple index that can be done in day-to-day practice, which helps us to classify the patients as mild, moderate, and severe. And coming to the next, so the laboratory tests, the common biomarkers. Day-to-day practice, we use the ESR and C-reactive protein. Very specific, but it does give us some information on the activity of the disease, whether this disease is in remission. Can you all please mute your... Okay, and includes the fecal calprotectin and fecal lactoferrin. And the cutoff for the CRP is less than 5 to 6 milligram per liter. Fecal calprotectin and fecal lactoferrin, they are quite specific for intestinal inflammation. And we have the values mentioned here, between 50 and 250 for fecal calprotectin and fecal lactoferrin are 7.25 to 10 milligram per gram, which is almost similar to fecal calprotectin. This is what we do in our day-to-day practice. It is an expensive test. So we do that in patients who have a flare, and we're not quite convinced whether it is a flare due to IBD or it is otherwise an unknown cause for the flare. Coming to the last bit, the endoscopic scoring systems, we've already discussed this. The E1 is rectum involvement, E2 is left-sided, E3 is extensive. And for the severity, we have patients who have no symptoms, those with mild ulcerative colitis who pass motion 4 to 6 times per day or less than that. Moderate are those who pass more than 4 times with minimal systemic toxicity, and severe ones are the ones who have florid systemic symptoms such as fever, low hemoglobin, and raised ESR. This we've already discussed, so I'll not be mentioning, except to mention that majority of our patients are proctitis, and they have the classical tenesmus and urgency. The left-sided colitis presents with a minimal abdominal cramp and all other findings of proctitis. And the pancolitis has systemic symptoms. Most of them have systemic symptoms, and they are the ones who have severe forms of disease. So we have two scoring systems for endoscopic assessment. We have the UCI scoring and the Mayo score, and it is shown here. And if the score of UCIs is 7 to 8, it is severe. For the Mayo, it is 3. So these are the simple endoscopic scoring systems. While reporting an endoscopic colonoscopic report, we use this calculator and mention to the patient whether in the reporting system whether the patient has mild disease, a moderate disease, or a severe disease. I think so. With that, I'll just mention, just to conclude, that in day-to-day practice, simple scoring systems like clinical scoring, laboratory scoring system, and endoscopic scoring systems are sufficient for us to guide us towards management, whether the patient would require a medical treatment or a surgical treatment, or we have a treatment schedule where the two of us combine together to help the patient to help in recovery as well as in maintaining remission of the disease. Thank you for your kind attention. Thank you, sir.
Thank you. Thank you, Dr. Jayanthi. I think that was a very brief and crisp presentation. And we've covered most of these are regularly used scoring systems, which are being used for clinical scoring and for endoscopic scoring. I think overall, we've covered the initial aspect of ulcerative colitis, the medical management, the assessment of the severity and extent, the indications, and the surgical treatment. I think the basic things which are important is, again, it's a disease which requires a multidisciplinary treatment with both the medical and gastroenterologist and the surgical gastroenterologist, especially in the acute phase, working together and taking decisions together to have a better outcome for the patients. And other important thing, which again I would like to highlight, is preoperative counseling is very important. And for these patients, planning a procedure should be customized to every patient. And we should err on the side of doing a 3-stage procedure if the patient is sick and on immunosuppressors rather than a 2-stage procedure. And the details of the procedure have been well covered by Dr. Das. I think with that, we can conclude the session today. Thank you, everybody. Thank you, Dr. Jayanthi, Dr. Sujoy, Dr. Das. And thank you all students for participating. Thank you.
Thank you very much, sir. Thank you and good night. Thank you.
Good night.
Thank you.
Good night. Yes.